So friends, in a previous chapter we have discussed about how parasympathetic and a sympathetic system forms, function of these systems, and formation of acetylcholine, the receptor of acetylcholine, that is a nicotinic and a muscarinic receptors. And further one we have discussed about the drugs which are involved in the parasympathetic activity, which decrease the parasympathetic activity, or the drugs which increase the parasympathetic activity. So we have discussed the 4 drugs in the last video. Now we are discussing about the drug acting on a parasympathetic system, that is parasympathomimetic and parasympatholytic. Okay guys, so parasympathomimetic, the drug which stimulate parasympathetic activity are called parasympathomimetic, means which mimics the parasympathetic activity or which stimulate the parasympathetic activity. So these are the parasympathomimetic, or we can say that cholinomimetic. We can also say them cholinomimetic. Other one is parasympatholytic. Drug which block parasympathetic activity are parasympatholytic. Okay, so these are the two types of parasympathetic system, parasympathomimetic and parasympatholytic. The parasympathomimetic, drug which stimulate parasympathetic activity; parasympatholytic, drug which block the parasympathetic activity. So first we discuss about the parasympathomimetic. Okay, so parasympathomimetic is further classified into two types, that is direct or other one is indirect. What are the direct? The direct parasympathomimetic drugs which are directly act on the receptor, that is a nicotinic and muscarinic receptor. The drug which direct acting on the receptor, that are called direct drugs, that is parasympathomimetics. Other one is indirect not act on the receptor but increase acetylcholine. They are not acting on the receptor, they are not acting on a nicotinic or a muscarinic receptor, they are increase the acetylcholine. So if acetylcholine increase, the receptor will stimulate. So how we can increase the acetylcholine? By inhibiting acetylcholine esterase. If we inhibit acetylcholine esterase, then acetylcholine will increase because the metabolism of acetylcholine decreases. acetylcholine esterase क्या करता है? वो डिक्रीज करता है acetylcholine को, मेटाबोलाइज करता है acetylcholine को. If we decrease the acetylcholine esterase, so metabolization of the acetylcholine will decrease. So indirectly acetylcholine will increase. So these are acting indirectly. So that's why they are indirect drug. So first of all we discuss about the direct. So in direct drug we are talking about the 4. So first one is pilocarpine. Pilocarpine act on the pupil. So pilocarpine act on the pupil. So what it does, it causes the meiosis, because parasympathetic activity when stimulated, the pupil will contracted. So pupil, if pupil contracted, then we call this meiosis. So which receptor will stimulate for acting on the pupil? M3 receptor will stimulate by pilocarpine for meiosis. Okay, next one is bethanicol. Bethanicol, bladder, it act on the bladder. So what will happen? If bethanicol stimulates the parasympathetic activity, it stimulates M3 receptor and bladder will contract. Okay, next one is methacholine. Methacholine act on a myocardium. If parasympathetic activity is stimulated, what will be the action of myocardium? Decrease in the heart activity. Okay, it will decrease the heart activity. When it can be used? So when person have a tachycardia, if person have a high heart rate or increased heart rate, we can use this drug to decrease the heart rate, methacholine. Next one is carbachol. Carbachol having a common action. It can activate, it can both stimulate nicotinic and muscarinic receptor. It will acting on nicotinic and muscarinic receptor both. Okay, so these 3 drugs, pilocarpine, bethanicol or methacholine, these are the specific for muscarinic receptor or M receptor. Okay, but carbachol acting on the both receptor, nicotinic as well as muscarinic receptor. The next drug which we are talking about, that cevimeline. The cevimeline drug stimulate M3 receptor. It stimulates M3 receptor and it used to treat xerostomia, that is Sjogren syndrome. That is Sjogren syndrome. So cevimeline used to treat xerostomia. It will stimulate the M3 receptor. Now move to the another point, that is indirectly acting drugs. So what are the indirectly acting drugs? They indirectly increase the acetylcholine by inhibiting acetylcholine esterase. They are inhibit the acetyl esterase. Okay, so it increase the acetylcholine in the synapse. So how we can inhibit acetylcholine esterase? So these are of two types. One is reversible, another one is irreversible. Irreversible, that is not much used in the clinically, because we cannot irreversibly inhibit acetylcholinesterase. We inhibit acetylcholinesterase for sometimes for a treatment purpose. Okay, so irreversible, that is not clinically used. So now move to the reversible point. Reversible, these are of two types, lipid soluble and water soluble. Lipid soluble and water soluble. So which are the lipid soluble? Physostigmine. Physostigmine are the drug which is lipid soluble, and neostigmine are the drug which is water soluble. Water soluble drugs do not cross the membrane, but lipid soluble drug can cross the membrane. What are the membrane we are talking about? That is GIT membrane, blood brain membrane, or corneal membrane, etc. So water soluble drugs cannot pass the membrane, cannot cross the membrane, but lipid soluble drug can cross the membrane. Lipid soluble drug, that is physostigmine, these are the natural which obtained from plant, and these are the synthetic. Water soluble drugs are synthetic. These are the tertiary amine, these are the quaternary amine. What is the meaning of tertiary amine? That is nitrogen have 3 valency, the hydrogen group attached, ammonia, that is NH3. So these are the ammonia, and if we are talking about ammonium ion, so what will happen? Nitrogen will attach with 4 hydrogen and plus charge is obtained. So these are the ammonium ion, or these are the ionized form. So water soluble drug, that is neostigmine, these are the ionized, and a lipid soluble, this is non-ionized. So here is physostigmine and neostigmine. So as we are talking about, physostigmine cross the membrane, neostigmine do not cross the membrane. These are the water soluble and these are the lipid soluble. So which membrane can physostigmine passes or crosses? There is the GIT membrane, blood brain membrane, pupil corneal membrane. Because it pass pupil corneal membrane, that's why we can use in glaucoma also. So physostigmine can used in glaucoma or treat glaucoma. Okay, physostigmine can given orally and neostigmine can given by the injection. Okay, so there is a no central effect because it directly injected, so there is a no central effect. Now there is another point, physostigmine. Physostigmine are the drug of choice for atropine poison. Really, if you are talking about atropine can cross the blood brain membrane and it reaches to the brain. So we need the drug which can cross the blood brain barrier or blood brain membrane. So physostigmine can cross blood brain membrane. Physostigmine 50% reach to the membrane and 50% outside. So it can treat the atropine poisoning by reaching the brain. Okay, so in atropine poisoning, what will be happen? Atropine block all M1 and M2 and M3 receptor. If we have to treat atropine poisoning, so we must have to stimulate M1 M2 M3 receptor. So we have to increase acetylcholine, and to increase acetylcholine we have to decrease acetylcholinesterase. Okay, if we need to decrease acetylcholinesterase, so we can use the physostigmine drug. So physostigmine indirectly increase the acetylcholinesterase by reaching to the brain, and 50% in the outside. By reaching to the brain it treat poisoning, and in a outside it treat peripheral symptom of atropine poisoning. Okay guys, because atropine can reach to the blood brain membrane, that's why we need the drug which can cross blood brain membrane and treat the poisoning. So physostigmine are the suitable drug to treat the atropine poisoning. So here is another brain related disease. These are the brain, and these are the basal nucleus of Maynard. Here is acetylcholine. So basal nucleus of Maynard, this is responsible for the memory. Okay, these are the responsible for memory, and directly we can say that acetylcholine is responsible for the memory. Okay, so neuron cannot divide so neuron die due to the aging. As person get older, the neuron will die, acetylcholine will decrease. So if we have to increase the memory, we have to increase the acetylcholine. So due to the decrease of acetylcholine, memory loss, and what we are calling that is dementia. And these are the age related disorder. So these are the senile dementia, and we called them Alzheimer's. Okay, we are calling that Alzheimer disease. So in Alzheimer disease, memory loss occur. So we have to increase the acetylcholine. How we can increase the acetylcholine? Yeah, we can increase acetylcholine by acetylcholinesterase inhibitor. If we inhibit the acetylcholinesterase, it will increase the acetylcholine. So we have to increase acetylcholine in the brain. So we have to use the drug which can cross the blood brain membrane. So physostigmine can cross the blood brain membrane, and it can use to treat Alzheimer, but we cannot use this. Why we cannot use this? Because it has a peripheral side effect. It can reach to the peripheral also and reach to the brain also. So in brain we can use that, but in peripheral it stimulates the M1 M2 M3 receptor, so there are a peripheral side effect. That's why we cannot use physostigmine. These are the only cross 50% of the drug which cross the blood brain membrane. Okay, so we have talking about the another drug which can cross the blood brain membrane completely. So now comes to the tacrine, and tacrine 100% cross blood brain membrane. But tacrine also have some disadvantages, and it was used previously, not used today. So what are the disadvantages of this drug? Okay, these are the short acting. So tacrine is short acting. So if tacrine is a short acting, we have to use this several times. We cannot use the drugs several times. So these are the disadvantages. And another disadvantages is tacrine is hepatotoxic. It means it damages the liver. So it has two side effects, that is it is a short acting, and another one is hepatotoxic. It damages the liver, so we cannot use tacrine. Okay, the safe drug are donepezil, rivastigmine, galantamine. These are the drugs which are safe to use in Alzheimer disease. Okay, we cannot use physostigmine because it has a peripheral side effect, and it stimulates M1 M2 M3 receptor, and it can cross M2. If stimulate M3 receptor, it cause bradycardia, it decrease the heart rate. Okay, in M3 it can cause diarrhea, stimulate GIT and it cause diarrhea. In M1 it can cause lead acidity. Okay, that's why these have the peripheral side effect. That's why we cannot use physostigmine. And tacrine has also disadvantages, that is it is a short acting and it is a hepatotoxin, it cause liver damage. That's why we cannot use tacrine nowadays. So the safe drug are donepezil, rivastigmine and galantamine. So these are the safe drug to use in Alzheimer to treat senile dementia or Alzheimer disease. One is neostigmine, another is pyridostigmine, and third one is androphonium. Androphonium has a short acting, that is they have a 10-minute action. Okay, so these are the water soluble drug, neostigmine, pyridostigmine and androphonium. The major clinical indication of these drugs are myasthenia gravis. Okay, what are the myasthenia gravis? It is the autoimmune disorder. Okay, what are the myasthenia gravis? It is autoimmune disorder in which the formation of antibodies against NM receptor. Okay, so acetylcholine cannot stimulate NM receptor because these are the myasthenia gravis, and myasthenia gravis antibodies form and is attached to the NM receptor, so NM receptor activity decreases. If NM receptors decreases their activity, so it leads to the muscle weakness. So these are the myasthenia gravis in which muscle weakness will occur. But similarly the condition is cholinergic crisis also. In cholinergic crisis, there in this the NM receptor will increase more, and due to the increase of more NM receptor, it will lead to the muscle weakness. So how we can differentiate myasthenia gravis and cholinergic crisis? We can differentiate these two disease by androphonium. Okay, we can diagnose the disease by giving androphonium. So how we can diagnose by giving the androphonium? Let's talk about this. After giving androphonium, if person has the muscle weakness improve, it improves their condition. If androphonium given and condition will improve, if condition will improve, that means that is myasthenia gravis. And if androphonium will given and condition getting also worse, that means that is cholinergic crisis. Okay, if androphonium will given, it act on the nicotinic receptors, so it increase the nicotinic receptor. In myasthenia gravis we have to increase the nicotinic receptor, so it leads to the improve in the myasthenia gravis. But in a cholinergic crisis, if we give androphonium, it increase the NM receptor, and here we have to decrease the NM receptor, so there is a worst in muscle weakness, there is a worse condition for the patient if we given androphonium in cholinergic crisis. So we can differentiate myasthenia gravis and cholinergic crisis by giving androphonium. So after androphonium, now move to the another drug, that is neostigmine. So what the work of neostigmine? It increase the acetylcholinesterase. It increase the acetylcholine. So neostigmine can use in a myasthenia gravis because it increase acetylcholine, and by increasing acetylcholine, it can increase the NM receptors. So in myasthenia gravis, we need to increase the NM receptor. So it can treat a myasthenia gravis, but it leads to the other side effect, that it increase M1, M2 and M3 receptors. Okay, it can cause a side effect due to the increasing of M1, M2 and M3 receptor, due to the stimulation of M1, M2, M3 receptors. Okay, how we can block the M1, M2, M3 receptors? We know the drug, that is atropine. So atropine specifically block M1, M2 and M3 receptors. So we can use neostigmine plus atropine for myasthenia gravis. We can use neostigmine. Neostigmine work on NM as well as NM receptor, but atropine block the M1, M2 and M3 receptor, so we can use neostigmine plus atropine in myasthenia gravis. Now move to the another point, that is a cobra bite. So what will happen in a cobra bite? Muscle weakness occur due to the bite of a cobra. So if we have to improve the muscle weakness, now here we can use neostigmine plus atropine in treatment of cobra bite. In a cobra bite, there is a muscle weakness and the symptom is just like myasthenia gravis. That's why we can use neostigmine plus atropine for the treatment in cobra bite. Okay guys, now another condition in which we use neostigmine, we can use the neostigmine pyridostigmine like drugs, that is reversal of non-depolarized muscle relaxant. What is the concept? The drug, that is atropine and pancurium, we can use in muscle relaxant. What will happen? What are the concept? In this, it blocks the NM receptors. Okay, atropine and pancurium, it block the NM receptor, and if we block the NM receptor, what will happen? If we block the NM receptor, the muscle get relaxed. If we stimulate NM receptor, muscle weakness occur, muscle contraction occur. If we block the NM receptor, muscle will relax. Okay, so if muscle will relax, so there is a muscle relaxant, we can use atropine pancurium for relaxation of muscle. Okay, by this drug we can relax the muscle. So when we use muscle relaxant during the surgery, before the surgery, we use before the surgery. Okay, we use muscle relaxant in surgery or before the surgery. Okay, but muscle relaxant have a longer period of action. Muscle relaxant have a longer duration, longer period of action. So after surgery, we can use neostigmine and pyridostigmine. After surgery, we can use neostigmine and pyridostigmine with atropine. Okay, with atropine. So it stimulates NM receptors, it increases the NM receptor, and atropine block the M1, M2, M3 receptors. So NM receptor will increase, so muscle get contracted. Okay, so after surgery we use neostigmine and pyridostigmine with atropine, but before the surgery we have to relax the muscle, so we use atropinium or pancurium. Now move to the another drug, that is irreversible drug. So in irreversible drug, that are organophosphate and carbamide. In organophosphate, there are two drugs, that is malathion and parathion. The other drugs are also included in organophosphate, that is DFP, tabun, sarin. In carbamide, there are two drugs, that is carbaryl, propoxyl. So there are two drugs in carbamide, that is carbaryl and propoxyl. So these are the high lipid soluble drugs. Okay, these drugs are highly lipid soluble, and we know that the lipid soluble drugs can cross the blood brain barrier, blood brain membrane, or it can also enter through the skin, also enter in the blood by the skin also. When the farmer use insecticide, so it can be attached to the skin and it reach to the blood. When it reaches to the blood, it inhibits the acetylcholinesterase. By inhibiting acetylcholinesterase, it increases the acetylcholine, and as the increase in acetylcholine, it will stimulate the M1, M2 and M3 receptor. What are the cause of M1 receptor? It increases the secretions. What are the M2 receptor cause? increase the heart rate, decrease the heart rate and decrease the blood pressure, BP. It will decrease the BP. In M3 receptor will stimulate, it will cause meiosis, but in this case it contracts the pupil very much, high contraction in the pupil. That's why there is a pinpoint pupil. So in that there is a pinpoint pupil. So pinpoint pupil seen very rare condition under some of the rare condition, that is when pinpoint pupil will seen in carbamate and organophosphate poisoning, in carbamate and organophosphate poisoning, or in opioid poisoning also we can see in a pinpoint pupil, opioid poisoning, or in we can talk phenol poisoning. In this poisonings the pinpoint pupil will seen. Okay, but in acetylcholine estrase poisoning, we have not to think about this, we just have to think about the pinpoint pupil and the secretion. If the secretion will increase and pinpoint pupil both are seen simultaneously, then we have to understand that these are the ACE poisoning, or that is acetylcholine estrase poisoning. Okay, we don't have to think differently, we just have to know that acetylcholine estrase poisoning in which the pinpoint and secretion both seen. So here if we have to treat this poisoning, we can use the atropine, because atropine are specific blocker of M1, M2 and M3 receptors. So we can use the atropine as a drug of choice. Okay, this is the drug of choice for the poisoning of organophosphate and carbamates. We give atropine IV. Okay, we can give atropine as IV. There is a repeat entry or repeat injection given to the patient in 5 minutes till the signs of atropinization occur. As the secretion decrease, as mydriasis increase, or as heart rate increase, that time we have to stop this atropine. But if the secretion is not decreasing, so we have to continuously giving atropine between 5 minutes. Okay, so the atropine is a drug of choice in organophosphate and carbamate poisoning. So guys, here we have completed the parasympathomimetic, that is cholinomimetic drugs, and in another lecture or in another video we will talking about parasympatholytic or anticholinergic drugs.